Hello everyone, welcome back to the Stay Current podcast. I'm Cecilia Gijena from Cincinnati Children's Hospital, and along with Stay Current, we are sharing knowledge to improve child health around the globe. Today, we have another episode of the Intestinal Rehabilitation podcast, and as always, we have Dr. Paul Wales, the current director of the Intestinal Rehabilitation program at Cincinnati Children's Hospital.
I'm Paul Wales. I'm a pediatric surgeon here at Cincinnati Children's Hospital.
And Dr. Michael Helmrath, the prior director of the Intestinal Rehabilitation program.
I'm Michael Helmrath. I'm a pediatric surgeon, also doing intestinal failure surgery and research here at Cincinnati Children's.
Today, we have the 8th episode of the Intestinal Rehabilitation podcast, and we are going to talk about refeeding in an older patient. If you want to know how to refeed a neonatal patient, go back to the episode 7 where you can find everything you need to know about that. So now, let's start.
Like the recent slew of kids we have that are between 8 and 16 that were eating just fine, and one day, boom, they had a volvulus and they've lost 90+% of the bowel.
The benefit and the curse from a patient like that is that they do know how to eat. They've established that behavior.
We know that enteral feeding is really important for nutrition, but in older children, that is not the only main thing we get out of feeding, because the normal feeding behavior is important in many social aspects of life. That is why it's very important to take this into consideration when we are treating older patients.
So even if you can't cure this patient and get them off TPN, it's important to make compromises to optimize quality of life the best you can.
Perfect. So let's talk about how to restart oral feeding.
We want to try to mimic the most normal feeding behavior that we possibly can. I still prefer letting them eat by mouth orally. The general strategy is you want to push the macronutrient modules of protein and fat are well tolerated. Most of these kids don't tolerate simple sugars very well. So the general concept of pushing solids and minimizing fluid intake helps. They don't tend to dump as much. Smaller meals more frequently of solids separated from their liquids to a certain extent, and minimization of simple sugars.
Understood. So reduce simple sugars and make smaller meals and try to separate them from liquids.
Eventually, they'll be able to tolerate more and more, but we'll see a lot of these patients that have transitioned off of TPN, enterally fed, and then they come back having some problems later. And you find out when you take a close diet history that they've sort of fallen off the wagon a little bit, and they've gotten a little bit loose when it comes to some of the diet choices.
And something important they highlight is to be very careful with the diet, because the increase in sugars can create some problems with the absorption and changes in the stool. So if you encounter a patient that comes with high stool output, you will probably want to see how its diet changed.
And not only that, but also sort of symptoms related to bacterial overgrowth by minimizing some of those sugars. They tend to be less bloated and gassy.
Now let's talk about rehydration and fluid management in these kids.
So we're in the older child that has fluid losses, whether it be by stoma or any other source, we have to replace. If they are parenterally supported, that some of that fluid can be replaced IV. But as you're trying to move forward to get off IV support, if you can keep them hydrated by replenishing losses through enteral replacements, then that's important. For transport requires sodium and glucose. And so your solution that you're replacing with has to contain some glucose and some salt.
So take into consideration if the patient has some IV parenteral support to replace fluids. If not, or you are trying to wean them off, you have to use a rehydration solution, because the ionic composition is really important.
And there are some homemade recipes for oral rehydration solutions. There's some over-the-counter type preps that you can get as well. Some people will resort to things like Gatorade and stuff like that, but that doesn't always work that well. It's actually too much sugar in it.
I think some patients actually can come off a TPN but still need a central line for IV fluids, and that in the absence of IV fluids, really they end up sleeping most of the days. They don't have a lot of energy. And it's hard to recommend back to a family that's lost the kids come off TPN and you're seeing them. But being in a hydrated state is extremely important to making the bowel work well. And the compromise over time is the ability to stay hydrated, whether it's at night through hydration, maybe even via G-tube, or emphasizing the need to stay hydrated. Sometimes they can't drink it, but the GI tract can use it.
Okay, so keeping the patient hydrated is very important. And for that, we have many options. It can be by mouth, by nasogastric tube at night, or IV fluids.
The other key point to remember is that the energy use goes up dramatically during puberty. And so you often will find a child who is actually doing well and they hit the wall when they start puberty because their energy needs are overcoming their nutrient input. The goal is always healthy growth. And so it's not lost to go backwards and to add things and supplement things and to hope sometimes that they'll take that one extra can of boost.
It's all about normal growth parameters and get them through puberty. It is true. Some kids end up back on parenteral support, to get through puberty. And then when you're not growing anymore as an adult, often that borderline or marginal gut function is enough to sustain them.
That's really important. We have to be aware of puberty and moments of increased energy needs to guarantee a healthy growing. As the doctor said, we have to be proactive and keep our patients ahead of that to avoid losing opportunities for healthy growing.
I can't emphasize enough to look at the growth chart, both the weight but also the height, and don't accept a third percentile. There is very few conditions with intestinal failure that have restricted growth. So, you really need to put them in a healthy growth range, and the family needs to recognize that they have the potential to do that. And so it's just setting expectations.
You have to grow off TPN, but also then you have to monitor. For a lot of the time you get into trouble after you get off TPN with micronutrient deficiencies, etc. That all needs to be followed, and then their long-term growth and outcome needs to be followed. So hence the importance of teams, these multi-D teams.
As always, we emphasize the need for a multidisciplinary team to help with the long-term follow-up and surveillance. Guaranteeing healthy growing is very important, and many of these patients don't have restricted growth, so we don't have to settle for a third percentile.
You have to grow off TPN, but also then you have to monitor. For a lot of the time you get into trouble after you get off TPN with micronutrient deficiencies, etc. That all needs to be followed, and then their long-term growth and outcome needs to be followed. So hence the importance of teams, these multi-D teams.
There's times that you do not get to go back. So a multidisciplinary approach, highlighting this really from the get-go, is really important.
Again, to help our patients, we need a multidisciplinary team and set expectations to be met. Because I think we can't emphasize enough that these patients can and should achieve a normal growth. Now let's talk about how we follow these patients and make sure that they are normally growing.
We track weight a lot as a major metric for growth, but it has to be balanced with their height. What we commonly see in this type of population is round babies where their weight for height is elevated. Weight and height are basic metrics, anthropometrics that you can follow in a clinic setting or hospital. But there's an increasing amount of data looking at, quality of weight. How much is fat weight and how much is lean body mass?
Great. So check weight and height, but also it's important to assess the type of weight they are gaining because it's not the same fat as body mass. And now let's hear what we have to do if these patients are not achieving a good weight.
Any child that's not meeting growth potential, there's numerous other diagnoses that can do it that range from endocrine issues to pancreatic insufficiency issues to micronutrient issues that are there. There's a lot of things that you have to check off. But your concept is that they're capable of having normal growth. And then as you address the issues and you improve something, You need to then have a reasonable follow-up time and assess that you're making improvements in that, which are on the orders of weeks and not months. And they don't need to travel for us to get a weight and to check them. You can do a lot of this stuff remotely, but you can't wait till the next appointment.
Amazing take-home points. Let's summarize. Enteral feeding in older patients is not the only main thing we get out of feeding, because many social aspects are involved. Diet is really important, and we have to avoid simple sugars, make smaller meals, and try to separate them from liquids. One main thing about these patients is that we have to keep them hydrated. And to achieve that, we need our special rehydration solutions, NG tubes with rehydration by the nights, or even IV fluids. Because if our patients are not hydrated, they will not achieve a healthy growing. As we always say, multidisciplinary team is really important, and they will help us to follow our patients in the long term. To check our patients, we not only have to see the weight, but also the height, and compare them to avoid having fat, short kids. And in some cases, we need to have another tool to acknowledge that the patient is having a healthy growing. So that was everything for today about how to refeed older patients. If you like it, leave us a rating or a review. Follow us on social media and our YouTube channel. Download the Stay Current app in the Apple App Store or Google Play Store, where you can find this podcast and a lot more. But until then, I'm Cecilia Gijena from Cincinnati Children's Hospital, and along with Stay Current, we are sharing knowledge to improve child health around the globe.